Hi there, good evening. Live on Facebook, got my questions here to answer. There's my camera, I think the camera's there. Got a few questions this week, and as ever, if there's any questions live, then please do feel free to ask away, and I will be very happy to answer them as we go. So Rebecca, you got a question here about is 5.5 weeks too early to be having personal training sessions? Yeah, I think that is too early to be having personal training sessions. It's breast augmentation, isn't it? I think it's breast augmentation. So 5.5 weeks is a little bit too early for that. I normally say around about 6 weeks. So around about now, you can start getting back into the gym. But the personal training sessions for me conjures up an image of a personal trainer sort of really making you work hard. I guess that's what their role is. I'm aware of their existence. I haven't got any personal experience of personal trainers, I'm pleased to say. But for those people who want to get fit, then I think they do probably push you quite a bit, and I don't think that's a good thing to do too early on. So I think after 5 or 6 weeks, you can start getting back into the gym. I'd encourage you to go to the gym. I'd encourage you to take it easy, but either not go with a personal trainer or tell the personal trainer you're supposed to be easing into it. But it's probably not worth having a personal trainer for that reason, because personal trainers are there to push you. So I'd say start gently to start with, and then after a couple of weeks, see how you go and build it up. And then when you feel comfortable, and if it doesn't swell up and it doesn't hurt, then you can definitely do more with that. Amy, I've seen a few articles on YouTube. But, that was a really good question. That was about autoimmune problems. What is the link and likelihood cause? I know you can breathe it. Yeah. So that was a really good question, Amy, about the autoimmune problems with breast implants. This goes back to quite about a few years ago, like I think it was back in the 70s. There was a big thing in America where a whole load of people came forward and said that they got problems with, they had breast implants in and they got problems. Rheumatoid arthritis, SLE, connective tissue diseases, autoimmune problems, and they said that they felt that the problems were caused by the implants. You had people who had twin sisters who didn't have implants who were fine, and it's quite a powerful group of people put forward this this hypothesis that there was a link between their problem, to the extent that the Americans actually banned silicone implants. So silicone implants were banned for a long time in America, and they were only able to use saline implants. And that is why still, if you look at a lot of American websites, they still talk quite a bit about saline implants. We've always used silicone implants. We never banned them. And there has been some really big studies, quite large scale studies, looking for an association between implants and connective tissue disorders and autoimmune problems, and then no link has been found. And so now they are back reinstated in America. So America, they can use silicone implants back in America, and we've very rare for any UK surgeon to use saline implants. Most people use silicone implants because they are superior to saline implants, and it's very rare to use saline implants in this country. Saline implants do actually have a silicone shell. Now, the only thing I would say is there's no association shown between silicone implants and connective tissue diseases or autoimmune diseases. That doesn't mean there isn't a link. There's a lot of stuff we don't know, and all we can do is look for the science, look for a link, and all I can say is we haven't found a link, so they are deemed to be safe. We've always used them in the UK since they came out back in the 60s, and they now do use them back in America. So, you know, whether something comes out tomorrow to say, oh my goodness, there is a link and all these people were right, I don't know. I have to say I do occasionally, and it is very occasionally, see someone who feels that the implants have made them feel ill, and if you take the implants out, they feel better. It's an anecdotal, it's not very scientific, that, but there are still people who feel that they are making them feel ill, but I've got to say they're in the minority. The vast majority of people don't have these problems, but nevertheless they're out there, so you should know about everything to make an informed decision about whether it's right for you. So yeah, so there is that is out there about the autoimmune thing. But as I say, from a scientific point of view, there's no evidence to support it. And it's the fact of the matter is that so many people are having implants. They just found that occasionally you get someone who's having an implant who then gets, you know, SLE or gets a connective tissue disease, and they think that the implant caused it, when in fact it was, they might have just, you know, when you get these diseases, there has to be a day that you get it, and then occasionally there'd be a, you know, you happen to have it just after getting an implant, so you thought it was due to the implant, but it may have been a coincidence. So that's a really good question, and that's where we are at the moment. No evidence for it. I'm not saying there isn't a link, I'm just saying we haven't found one. If there is one, there's all sorts of things that could be linked, but we have to just say what we know about. Then we've got Mary. What incision do you make for breast augmentation, and what is your technique for mastopexy? So incision for breast augmentation, pretty much there's different incisions. You can make it in the inframammary fold, the fold where the bra sits. You can make it in the lower part of the areola, just below the nipple, as a U shape, and you can make it in the armpit. Those are the sort of common, well, those are the common ones. I pretty much always go for the inframammary fold, about 5 centimeters long. In the inframammary fold, because I think it's the best one for several reasons. I think it gives you good access to the breast, it gives you good visibility for the pocket that you're trying to create, and it's something I'm familiar with. Having said that, I often get people, well, not often, sometimes get people who want the armpit incision, and don't think I've ever seen anyone who wants the areola one, but anyway, and what I say is, look, find someone who's comfortable doing that incision. I'm not. And I have done the areola one. If I'm doing work on the areola, I would put an implant in that way if you're making a scar there anyway, but I wouldn't choose to do it if I didn't have to make that scar. And there's pros and cons with all the incisions. The areola one does settle very well, but if it doesn't settle well, then it's at the front of the breast. Also, there's a possibility of altered sensation of the nipple when you use that technique. And the armpit one, again, some people are used to it and are very good at it, and so I'm not saying it's a bad technique, but in my hands I find it hard to make it nice in the cleavage area, which obviously is really important. The cleavage is very important, and you're quite far away if you're going in through the armpit. You can't really see the cleavage area, and I always worry about bleeding and controlling the pocket there, so I think I would compromise on that. So that's why I don't use that incision, but some people do, so find someone who does if that's really what you want. I know a few people, but unfortunately the people that I know are all overseas. I know there's a chap in France and another chap in Norway, so I don't really know anyone in the UK who's got a big experience of that, but there may well be someone. So that's the incision for BBA. What's your technique for mastopexy? I'm not sure what you mean by that, Mary. People do obviously do a lot of research before they have surgery, and I think that is a good thing, and I encourage it. But I wouldn't be too worried. Oh, look, I can write a comment. Oh, what have I done? Sorry, you see it? I wouldn't be too worried. Oh, Amy. Oh God. Okay, Amy, I see you've got a question there. I won't be too worried about, I will answer your question in a second, Amy, about techniques for mastopexy. I'm not sure what you mean by technique. There are lots of different techniques for mastopexy, and I can certainly talk about the way I do a mastopexy, but as a general rule, it involves repositioning the nipple to a higher place on the breast. Maybe what you're talking about is the scarring, because that's something that people do I want to say delineate, is that an appropriate word? But you know, they do. There's different ways of doing. I can't focus on the question and answering another question at the same time. They do. You can separate types of mastopexy by the scarring involved. It's always a scar around the nipple. That's the circumareolar mastopexy. I pretty much never do that. I don't like it. I don't think it gives a good shape to the breast. And for me, out of all the scarring, so you go round the nipple, then you can have round the nipple and straight down, which is your lollipop, your circumvertical, or round the nipple straight down and then in the fold, which is your anchor or inverted T. The most obvious of those scars is the round the nipple one. That's the one you have to have. So, you know, if you could avoid having that one, I think that would be a useful technique to do, to avoid that one. But the only ones you can avoid the one in the fold, but that's often not really a problem. So I use the circumvertical sometimes, so around the nipple and down, and I use the inverted T at other times. A bit like what I've said in the past, no one wants scarring, everyone wants less scarring. The less scarring you make, the less skin you can take out, the less of a lift you get, because the whole point of a lift is to tighten the skin. and so less scarring means less lift. So it depends on how much skin there is to remove. So if there's not much skin to remove, I'll do the circumvertical, and at the end of the circumvertical I often take out a little dog ear at the bottom, so I often make it into a little short T. But then if there's more skin to take out, I'll make a longer T. I'll make the scar in the fold longer. So that's the skin pattern I use. Again, techniques for mastopexy can depend on how you keep the nipple attached. I usually use a superior pedicle if that's helpful to you. Keep the nipple attached in the upper part, release the breast in the bottom, and lift and mobilize the breast up into the top half of the breast pocket to bring the volume up there. And I don't tend to use any internal stitches, and I don't use any internal devices. There's devices you can use, dissolvable meshes. I tend not to use those because I worry about being able to feel the mesh and if you get infection in the mesh and things like that. But it's something we can definitely talk about. These are not in common use in the UK, but we can definitely talk about these things. And I hope that's what you're talking about. I think that might be what you're talking about with regards to mastopexy, the different pattern of scarring. So Amy, we've got a live question, which is exactly what I've always been after, and I salute you for that. What is a partial placement, Jonathan? Would this be any better for me than overs? Would this prevent being able to see the implant edges? Okay, partial placement. So partial, what you're talking about is partial submuscular. A lot of people say, oh, should I go submuscular? Oh, should I go total? Oh, I could go partial submuscular. That's got to be better than going fully submuscular. Different things. People mean different things by this partial submuscular, what have you. It's very rare to do a total submuscular placement of the implants. In a cosmetic situation, the implants are always partially submuscular. The only time you do a total submuscular placement of the implant is someone who's got cancer, who's had a mastectomy, he's got nothing there at all. Then you will need to get the implant totally covered in muscle. So you use, as well as the pec major muscle, you use other muscles from around the area to get total submuscular coverage. So a cosmetic augmentation, when it's under the muscle, is always partial submuscular. The outer part of the breast, the outer part, the lower and the outer part of the breast is always not under the muscle. I guess you call that on top of the muscle, which you. So partial submuscular is a normal, all submuscular implants in my hands are partial submuscular. There's different types of partial submuscular. There's dual plane. You might have heard of that technique. Again, I've heard people talk about that in the website, not on the website, in the web world, internet, as you people call it on the internet. I've heard people talk about dual plane. Again, it's a bit like the mastopexy technique thing. You know what? I wouldn't get too involved in it. If you were having a dual plane, Amy, you'd be having a dual plane type 1 if that's helpful to you. It depends on how much of a droop you've got to your breast. If people have got more of a droop to your breast, you'd have a 2 or a 3. I don't know how. I don't think that's any help. I wouldn't have thought to a patient, but maybe it is. So there's different types of dual plane. Or different types of partial submuscular, if you like. The bottom line is, your question is, would it prevent being able to see the implant edges? Yes, is the answer to that. Having some muscle over the top of the implant will prevent being able to see or feel the implant edges. That is the point of putting it under the muscle, depending on which way you put it under the muscle, but that is what the muscle does. It gives them implant cover. So when you ask that question, the answer is yes. The problem is when you start raising the muscle, in whichever way, you can get complications with raising the muscle. It's a bit more uncomfortable because you're cutting the muscle. So every time you move, it hurts a bit. It bleeds a bit more because you're cutting the muscle. And when you exercise, you can get animation deformities. The muscles can pull the implant. Sometimes the muscles can hold the implant high. Muscles can hold the implant wide. So there are problems with putting the implants underneath the muscle, but there are also benefits. It's like anything in this world. It's pros and cons. And so it's a question of balancing them. So yeah, I mean, we can definitely talk about it. I think you're coming back to clinic, aren't you, Amy? So we're definitely happy to talk about that because, you need to be comfortable with where you're going to put it, because the problem with when you go on the internet, you'll see someone say, oh, I'm going to have it under the muscle because I don't want to be able to feel the edges because my friend had it on top of the muscle and she could feel the edges and it looked awful. And you think, oh my God, I better have it under the muscle then because it's going to look awful if I have it on top of the muscle. But then you're going to get someone else who says, oh, I had it under the muscle and I had my cleavage was really wide and every time I did my weightlifting, my breast moved and twitched and the implant sat high and it didn't look good. There's the problem with talking to people is the is that you're going to get that one person's experience, and some people have a good experience, some people have a bad experience. It may not necessarily due to the technique, and all techniques have got good and bad in them, otherwise we wouldn't do them. So we've got a follow-on question for Amy, bang on. So will the implant be directly in contact with the breast glands, as I'm concerned about breastfeeding in future and having pressure from the implant and getting a low milk production? Well, that is way off. That's nothing. So whether it's on top of or behind the muscle, there'll still be pressure on the breast. The implant will give pressure on the breast, whether it's directly next to the breast or whether there's a muscle in between it and the breast. There will be some pressure there. You know what? It's not a huge amount of pressure. I don't know if you think it's going to be like some enormous implant squishing the breast. It's not a huge amount of pressure, and that the muscle, whether you have it on top of or behind the muscle, is not. I would not make the milk problem that you're talking about an issue. It doesn't make a difference whether it's in front or behind the muscle. The main thing about the you're reading too much. Well, that question's gone there. The main thing about the breast breastfeeding in the future, having pressure from the implant, getting a low milk production. The main thing about the milk production is the milk ducts. So when you do just a straightforward augmentation, again, go back to the incisions. So I tend not to make the infraareola. When you make the infraareola behind the nipple, you might possibly cut some ducts. I pretty much always use the inframammary, so I'm not cutting any milk ducts. I'm not cutting any in breast tissue. So you're just going underneath the breast tissue, and you're going underneath the breast tissue whether you're going underneath the muscle or not. You're still going underneath the breast. It's either underneath the breast or it's underneath the breast of the muscle. So you're not actually cutting any breast tissue. So everything's pushed and pulled and stretched, and you do feel a bit numb and feel funny feelings. But your ability to breastfeed should not be altered by having implants. So if you can breastfeed already, you'll still be able to breastfeed after having implants. The implants will not make you not breastfeed or give you a low milk production due to pressure. I don't know if you've got this, Amy. If you've got this from, I mean, the thing is, I don't know everything. You know, if you've show me if you've got something online, because I'm worried now. You've got this low milk production by pressure on the breast. I haven't heard of that. But if you've got something that says that, then show me and I'll have a look at it and see if there's any evidence for it. I'm not aware of any evidence that says implants on top of the muscle squeeze the breast tissue more and give you more of a low milk production than implants under the muscle. I've not heard that at all, and I don't think it's not something I'm aware of. I don't know if you've got a scientific thing on the internet or if you've got some person who had implants and said I had low milk production afterwards. It's a bit like going back to the thing right at the beginning about the silicone saying making the implants made you feel ill. Someone out there might have had implants, had less of a milk production for a baby after the implants and thought that was due to the implants, when in fact it might be just they had a bit less milk production because their diet wasn't so good or they weren't in such a good health or they're a bit older or whatever. I don't know. There could be lots of reasons for a low milk production. I'm not aware of any evidence to say that implants pushing on it causes that, and I'm also not aware that having them under the muscle gives less pressure and is more of a thing about milk production. There are some very well known and well documented pros and cons of them putting the implants above or below the muscle, and if I was you, I'd make your decision based on those things rather than the milk thing, because I don't think I think that's a bit of a red herring there. I think your milk should be fine whether you have it above or below. So that was an excellent, Amy. You've done a blinder this week. Not only have you asked a question pre-operatively or pre today, you also asked questions live, so that's double gold star for you. Well done. Anyone else want a gold star and ask a question? Please feel free. I do sometimes see questions afterwards, so I do feel terribly bad about that because I don't know if I'm doing something wrong, but clearly Amy's got one in there, so there is a facility to ask questions live. So if you have got any questions, then please do post them on here or email us, or if you are posting it as we speak or have posted one and I'm totally ignoring you, I can only apologise because I haven't seen it, but I will pick it up later on. So I'm going to check right out of here now, if that's okay with you guys. And I'm going to see you next week at 7 o'clock here on the Facebook Live. So please ask away questions. And see you soon, Amy. Thanks very much, and thank you. And so check you out see you next week. And I will check out right now. And looking forward to seeing you in the clinic, Amy. Bye. I'm just going to finish the button now. Okay. Right, okay. So just talk amongst yourselves, and I will just